Hello, everybody. Welcome to episode 8 of the Apollo Educational Series. My name is Arash Tagvai, and I'm one of the patient care specialists and medical graduates that works at the Apollo clinics. Today's topic is a very special one, and it comes with a very special demographic, ASD, or Autism Spectrum Disorder. I'm going to go over all things related to the condition, how cannabis can potentially help this demographic and the patient's caregivers, and also I've prepared a couple of cases for us to review at the end as well. We have a special guest appearance from the one and only Dr. Paula Williams, who is one of the physicians at Apollo that works closely with this demographic. I'm actually going to get started with her, so let's get going.
Hi, I'm Dr. Paula Williams, physician at the Apollo Cannabis Clinic and grandmother of 5. I'd like to say a few words about some very interesting and rewarding work that we also do at the Apollo Clinic. We see very small children, as well as teenagers and adults, of course, but small children is something new for us in the last few years. We started to get quite a few referrals from parents and from pediatricians of children who have some version of autism spectrum disorder that may include Asperger's syndrome, behavioral problems, anxiety, sleep problem, that is getting up and running around the house all night, aggression, and sometimes lack of speech, a great deal of anxiety, sensitivity to stimuli of all kinds, and difficulties socializing with other children. In the same spectrum, we often see attention deficit disorder and behavioral problems, and we were also getting referrals for very young children with epilepsy. Some of them just had a few seizures, but some had syndromes where they would have as many as 200 seizures per day. These children were greatly affected, and their parents are most concerned. I'm very impressed by the devotion of the parents and their dedication to finding the best treatments for their children. They are often in chat groups, such as the Ontario Autism Coalition, and many of them had heard about our clinic. We developed a great deal of experience and expertise in prescribing medical cannabis for these children. What they get is the cannabidiol or the CBD form. It is not psychoactive, and it appears to be safe for children, there being no signal so far for harm, although it is early days and there are very few studies on CBD for young children. Cannabidiol is quite easy to give to small children. It is prepared as drops in a little bottle. You can put it in the child's mouth or into their juice. You can drop it on a cookie. An older child can handle a little soft gel. I've been really impressed by the effectiveness of the CBD in helping children with ASD and behavioral problems. It seems to reduce anxiety and the sensitivity to stimuli, which are very unpleasant for them. Sometimes the child's speech will be facilitated. The CBD cannot change the course of the condition or the cause, but it can really help the child succeed at school and at home and be more comfortable in himself or herself. Most of the time, it actually does help them. Occasionally, it doesn't work at all. We have not picked up any bad side effects.
There you have it. Some of the experiences from Dr. Williams. I'm going to be expanding on a few of the things that she mentioned, but what's important to take away from that video is how it is helping not just the patients, but also their parents. Let's dive a little deeper into the condition. Generally speaking, ASD is a developmental disability with a broad range of symptoms. They are generally characterized by a lack of communication and repetitive movement. That lack of communication can be speech impairment, or it can be nonverbal communication, and it can also be any kind of inability to express emotion as well. Okay, so it's important to keep that in mind. Previous to 2013, the Diagnostic and Statistical Manual of Mental Disorders, the DSM, had 4 different conditions listed here as where these patients would fall under. So there'd be Asperger's syndrome, which is high functioning on the higher level of the spectrum. And then you'd have autistic disorder, there's childhood disintegrative disorder, and there's pervasive developmental disorder, or NOS, which is non-other specified. These conditions are very variable in presentation, and of course, we're being variable in diagnosis. You can only imagine if a child was diagnosed with autistic disorder and became high functioning later and was moved from autistic disorder to Asperger's syndrome, well, then you have a physician who doesn't feel well about what he has said to these patients. And of course, the patients are very angry with the doctor because he got the diagnosis wrong. But now these 4 conditions under the new DSM have been collapsed and have been replaced by a spectrum. So if any of these conditions present and a pediatrician or a doctor recognizes this, they can say, well, this patient is potentially on the spectrum. Let's put them into a group, let's observe them, and let's treat them and see where we go and see how it can improve their quality of life or their condition. Autism is very, very interesting in how it presents and how variable it is. Sometimes we have patients who come into clinic and they are non-communicating. They will not make a single peep the whole time they're in clinic. Other times they will make loud noises or screams that are not comprehensible, but you can pick up on how they're feeling based on these noises. And other times we have patients who come in a follow-up manner and they speak with us, and you can tell that this patient really doesn't like speaking, but they're doing it. They go, hi Arash, how are you? I say, I'm doing well, how are you? And they respond by saying, well, I'm good, thanks, goodbye. And you can tell that is a person who no longer wants to be in the conversation. And of course, their caregivers are saying, wow, look at that progress. We are thrilled. He's talking to you. He's communicating again, right? And again, that is very simply put, the order in which a patient can be assessed when they're on the spectrum, okay? So it's very important to remember that it is variable in presentation, but generally they're all treated very similar. Unfortunately, there are no objective tests. I don't have an X-ray. I don't have blood tests. The diagnosis is made from the very stout observation of any and all caregivers, and then the missing of developmental milestones can be observed from a physician as well. So remember, observation from parents and developmental milestones. So if we zoom in on developmental milestones, we can discuss that all humans generally develop on the same timeline. Sounds strange to say, but at 12 months of age, a child should have at least 3 words in 13 and 20 months. A child should be able to stack 2 blocks on top of each other, or any stackable toy. At the age of 17 months to 24 months, they should be able to stack 4 blocks on top of each other. And the memory trick that we used in medical school is 24 months, 4 blocks. Just a way to get the question right or not get the wrong answer. So regardless, it's important for a physician to recognize these. So if a child is brought into clinic and they're 2 years of age, and the mother expresses that they do not stack any toys on top of each other, they are still not really communicating. They are humming and making noises, but that's really the only extent of their communication. Well, that is an immediate red flag for the physician. And he will potentially turn to them and say, well, this child seems to be on the autism spectrum disorder. So we can decide where, as we continue to monitor, as he continues to grow, or he or she continues to grow. Important to also recognize that there's a 1-to-4 ratio when it comes to females to males with autism. The theory behind that being is that the additional X chromosome in females gives them a little more protection compared to boys. Also, this condition is now being recognized and observed at a much higher and better level. Some of the initial analysis show that 1 in 59 children may be on the spectrum. It's also important to recognize that the spectrum does weigh functionality as a way of analyzing the patient. Some patients may be on the spectrum and be very high functioning. They may have a job. They may have an entire life, but they dislike communicating and they like to be more alone. Their 9 to 5 is basically to get through their day so they can go on and explore other things that interest them alone. Other times it becomes a lot more difficult for caregivers because that patient will refuse to communicate, will refuse to move forward in types of any kind of neurological development. And of course, that leads to low function in society. And you now have a patient that must be taken care of for the remainder of their life. And that is, of course, difficult to cope with for anybody who's involved in their care. Who does it affect? I thought this slide was very important for us to discuss where the condition is seen more of. And again, this is very, very preliminary information that we are gathering and we're learning, and we know that there is no specific connection to any one type of demographic when it comes to ASD. It is not race related. It is not geographically location related. If you're remembering back to our last video with multiple sclerosis, there's a higher incidence of MS in the further you get away from the equator, whereas with ASD, there is no geographical association. There's a small genetic association that does exist, but the exact gene or genes have not been isolated and have only been associated in about 20% of the cases of ASD that have been documented and tested for genetics. Some studies are connecting advanced maternal and paternal age to an increased association with ASD. And it's important for me to mention this now, because in the past, everybody thought, well, mom was older and it was a maternal problem. Mom caused this. That is not the case. That is not true. The same association that goes with advanced maternal age is linked to advanced paternal age. Both mom and dad, if their ages are higher, there is an increased association with ASD. Environmental factors are still being explored. A lot of parents and patients will say, well, it was after that one day we tried this, or after one day we went here and something scared him and he hasn't been the same since. But guys, that's not necessarily true. And none of those findings have been objectively proven again. And all of the research shows, again, that we have a lot to learn and we don't know exactly what the cause is. And these are all just associated treatment. Guys, this is a very important slide. This is essentially where a lot of ASD patients and their families, and they'll go through this stuff, okay? Starting at the very top, behavioral management therapy, okay? Cognitive behavioral therapy. ASD is very interesting in its presentation. Sometimes you may see an ASD patient that doesn't fully understand personal space. They are friendly, they are smiling, but they'll come right up to the individual and sit next to them. And of course, the individual doesn't feel comfortable when they're doing this, and the ASD patient does not understand why they're uncomfortable. This is an example of a lack of communication, both verbal or nonverbal, right? Again, these are the things that we see. Educational and school-based therapies, this is where a lot of attention has been being put. How do we get them out of the house? How do we get them into a school? How do we get them functioning in that school, right? This is important. Joint attention therapy, this is, again, very interesting. It's a form of nonverbal communication within a group, showing this interests me. Look at this. And they share with people. They may not say anything, but just, Or pointing. There's a bird. Look, everybody point and observe. And if they do that in a group, they recognize that humans work well in groups and that they should communicate with this group and they should be open to that group and not fear that or not move away from it or not be aggravated from it. Again, it's very important. Medication therapy or treatment, I put CBD in brackets there. Guys, this is where cannabis-based medications can play a very important role for these patients, okay? A lot of the medications that they use now for ASD are based on the symptoms that present. If an ASD patient is not sleeping for all hours of the night, well, then they will look to help with the sleep. If an ASD patient is showing signs of aggravation and aggression throughout the day, unfortunately, they'll go into the arena of antipsychotics to try and slow down that aggression. If the patient is constantly shedding tears or not in a good mood or struggling in other ways, they can potentially discuss mood stabilizers. And then in the other case that I prepared for this presentation, they can also go into the world of benzodiazepines. And these are medications that are designed to slow everybody down. I will review the medications in more detail when I get to the cases that I prepared for you guys at the end. Another important part is nutritional therapy. Again, some of the repetitive behaviors that come with these patients or their inability to communicate doesn't allow them to have full nutritional value in their day. They'll reject food or they will only eat one type of food. The condition in which a person only consumes one and excessive amounts of one food is called pica, P-I-C-A. Again, that is observed at a higher rate. We have physical therapy, social skills training, and of course, speech and language therapy. From the example that I mentioned earlier, the individual who understands he must say hello, he must respond to a question, and then he can say goodbye and leave the conversation. And you can tell it's not fun, but they'll do it. And that's from the speech language therapy that they've gone through. Mentioning medication in the previous slide brings me back to CBD, cannabidiol. Guys, I've discussed this chemical compound that comes from the cannabis plant many times before. But what we know is this molecule, this chemical compound, will connect to the endocannabinoid system, and that has receptors in our body that are already there, and it can help calm down anxiety. It can help control aggression. It can help with sleep potentially as well. Okay, it's very important for us to remember that CBD plays a role with these patients. It's helping them and it's helping caregivers. Their ability to cope will decide the quality of life of that patient, right? We have to remember how much work goes into these patients and how much work it is to have an ASD child in your home. Recognizing that CBD does help these patients, I've put another very simple slide for the endocannabinoid system, okay? Recognizing that these receptors are already in place in our body. Cannabinoids can attach to them. In this particular photo, it's showing THC, but CBD and THC have very similar receptors in the peripheral nervous system. And again, this helps release or increase reuptake of neurotransmitters that can help with mood, that can help with pain, that can help with aggression, and in this particular case, help with anxiety as well. As you heard Dr. Williams say, there is a large level of anxiety that comes with these patients. And again, it's difficult to understand. They cannot communicate why. We cannot understand how to help. So we have to look for alternative ways to help them feel better and for us to be able to. How can Apollo help? I've discussed with you guys how the condition would present. I've discussed with you a little bit as to how these patients are managed. We're going to get into more of the detail for management once I go over the cases, but the Apollo process is very important for us to cover. Guys, I've gone over this before, but just to reiterate, initially, a triage is required, okay? This is where we will understand their mother or their father or their caregiver has brought this patient into our clinic, and we are going to talk about the age in which they were diagnosed. If we are lucky, ASD can be diagnosed within the first 12 months of life, but generally speaking, it's diagnosed in years 1 to 3. The reason why it's important, the reason why I say if we're lucky with diagnosis, is that it is shown that the earlier any therapy for ASD is initiated, the higher the chance of success with that therapy, okay? If you allow the child to develop until the age of 7 or 8 before we start therapy, well, guess what? It's going to be a lot more difficult for us to be able to penetrate that thought process and understand what they need and teach them what they should also care for when it comes to themselves. So again, the earlier, the better. If I understand in the triage process that this patient was diagnosed at 2 years of age and they're now 3 years old and they're here, well, that's great. Now we have a chance. We can get the ball rolling and we can see what we can help with. Step 2 is the consultation. You will meet your doctor. You will have a consultation. You will discuss dosing as well. Okay. Step 3 is the medical document, your prescription. That will be sent for you to a licensed producer, which is a fancy way of just saying your pharmacy. After that, you will be followed by a patient care specialist or an educator, like myself, and you will be discussing all of the requirements for dosing, what to watch for, how to know if it's helping, which was one of the excellent questions we received that I'm going to discuss as well at the end. After that, you receive your medication, and of course that comes to you in the mail directly to your door. This process will be repeated in a follow-up, but of course it will be a lot shorter in length, and we will repeat this process several times until we learn what can help that patient, what can help that family, and hopefully everyone's doing better. I have also a couple of cases from Dr. Williams. I'm going to share them with you, and then I'm going to get into my cases, and then, of course, questions at the end, guys. Let's listen to Dr. Williams and what she has to say.
I can remember some cases quite vividly. For example, a little fellow of about 6 or 7 with autism who had been expelled from about 5 schools, and as his mother said, he has put 2 teachers into the hospital. He could not control his aggression. Coming back 3 or 4 months later, the mother reported he's been to a birthday party. It was a huge accomplishment. Many parents say the effect on their child is like night and day. They may get sleep for the first time in years as the child settles comfortably and does not try to escape from the house during the night. I can also remember twin teenage girls. When we first saw them, we had to see one by video in her family's car because they simply could not get her out of the vehicle. Over time, these 2 girls became calm and happy, and I was able to meet them in person. There are many cases like this. You might be saying, how can we see all these children in our clinic? Fortunately, we have always used video visits as well as office visits, and with COVID, all our visits are by video or by phone. We get enough information to assess the child and make a prescription. Parents are then sent to our educator who knows where to get the CBD that is suitable for children from one of the licensed producers, and they arrange the prescription for them. In 2 or 3 months, we follow up with the parents. This is a new field for everyone. We are getting referrals now from pediatricians and psychiatrists. Some of them are still not too familiar with the effects of CBD on children, and they are a little more reluctant to see us prescribe it, but I don't worry too much about the safety and the effectiveness of CBD, as I have seen it help dozens and probably hundreds of children over the last 3 or 4 years. Something interesting to consider, something very helpful. Think about calling the Apollo Clinic, where you will be able to speak to a physician, like me, or a nurse practitioner, and some very knowledgeable educators about whether CBD is appropriate for your young child or teenager. Bye-bye for now, from Dr. Williams.
There we have it. Some of the experiences shared by Dr. Williams. I want to kind of focus in on 2 of the things that she said. One, the amount of traction that medical cannabis is gaining in this demographic is very interesting. It's becoming very popular. And the reason for that being is because the current medications and the treatment options aren't really designed for ASD. I've said that before. I'm saying it again. I'm going to go over the cases that I have for you guys. You'll have a better understanding of it. But in all honesty, CBD gives these patients an option that did not exist before, and the results have been tremendous thus far. It's too early for us to have any real conclusions as we continue to learn the condition and how cannabis-based medications can help. But the traction is building quickly. Another thing that Dr. Williams also mentioned in her video is that you will be connected to a licensed producer, which I mentioned, but I want to just take one moment to say a licensed producer is a Health Canada approved facility. They have government approval to grow cannabis-based medications. And the medications that we use, as she mentioned in her previous video, will be drops or capsules for this demographic. We'll get into my cases, guys. I hate to use the word simple, but this is a slightly more simple case of ASD. And these were parents who were very open and understanding to this treatment option, and they wanted to give it a shot as soon as they could. So here we have a 10-year-old male diagnosed with ASD at the age of 3. HBI stands for history of presenting illness. So the HBI on this patient is the caregivers, which are the mother and father, mentioned that he has repetitive behavior, poor eye contact, nonverbal communication is present. He has aggression, excessive interest in objects. That's a very interesting one. Sometimes you'll hear about an ASD patient who is absolutely in love with just one object. Nowadays, it's a cell phone or a tablet, right? Rewind 10 to 15 years ago, well, they would be infatuated with the vacuum cleaner, or they would take apart the living room fan. Lamps didn't stand a chance in that household, right? And again, this is a child who cannot be communicated with and will obsess over one object. It also mentions here in this case, the sleep patterns. This is very important. And also before that, the aggression. So let me just read this back before I get ahead of myself, guys. Aggression has increased in severity as he continues to grow and gain physical strength. We have to remember that child is going to continue to grow and soon be an adolescent, a teenager, or an adult, and they still have the same communication problems and aggression as well. So again, these parents are saying, well, when he was 3 years old or 4 years old is okay, but he's 10 now. I have to be ready for that, right? He could do some damage if he really wants. And unfortunately, they can't communicate with him. And again, it becomes a little bit more unfortunate when you consider the circumstance. This is a child. This is every parent's true love is their children. And now they cannot communicate. And that person, that child is aggressive back towards them. Can you only imagine how difficult it would be for these caregivers? Moving on to the patient's sleep. He is also suffering from a sleep disturbance, waking several times per night and usually up no later than 6 a.m. Most mornings are as early as 4 a.m. Sorry, some mornings. Regardless, 6 a.m., 4 a.m. You never get past that. That's a lot of commitment and a lot of work from a caregiver. Current medications are 10 milligrams of melatonin, in which they stated it helps with sleep initiation, but does not help with sleep maintenance. He is still waking up throughout the night, but at least they're able to put him down. Current treatments include special educational camps and day programs. Treatment goals for Apollo will be to reduce aggression in the daytime, assistance with mood control, and sleep. I put down here a short blurb in the 3-month follow-up. The caregiver states that he is far less aggressive, his mood and his sleep have improved. His pediatrician was surprised. His caregivers were surprised. Everybody involved in his care thought, my goodness, what's going on? Something's changed, right? And they came back and told us that they started the dose in which the educator counseled them on, and they increased it a few times in increments that they were educated about, and they were able to find success. And again, when you feel that success, you recognize the relief that is involved with this family, with their ability to sleep in a little bit more, with their ability not to have to worry about the aggression. So again, these are just things that we see in clinic that I'm sharing with you guys. And hopefully this puts a better understanding on the scope of autism spectrum disorder. The second case, guys, is a little bit more complex. And again, I've just shared it because it gives us a better understanding of to what presents later in life. So let's go through this together. This is a 21-year-old male diagnosed with ASD at the age of 3. History of presenting illness is aggressive behavior, first and foremost. Self-injury, lack of verbal communication. Caregivers mentioned that he is not able to express pain or comfort. When this patient presented in clinic, he had a recent self-injury on his arm, and you can tell there was no way he wasn't feeling it. And they said the only way they would recognize that he was in pain is if he was very stiff. And anytime he had a self-injury, he would remain stiff for several weeks until that injury had healed, and again, he would be slightly relaxed, but the emotions were never present on his face. The sleep disturbance is quite bad, and to mention also, guys, anytime there is a neurological developmental disorder, there is a risk for seizures. If the seizures are very high in number or very severe in intensity, there will be a diagnosis of a separate seizure disorder. ASD has a high rate of seizures, as mentioned by Dr. Williams, experience shared. So the sleep disturbance on this, again, is very severe. He wakes up at 2 a.m., he wakes up at 3 a.m., wakes up at 4 a.m., not to sleep again, averaging anywhere from 4 to 5 hours of sleep per night. I've added here the physical exam, the PEX. He is 6 foot even, 185 pounds, right? Just to give a bit of understanding to the image of this case, right? This is an individual that is capable of doing some real damage, and unfortunately, we cannot communicate with him to explain what he should and should not do, and his frustrations are not being articulated or shared with anybody. Current medications: Zolpidem, 5 milligrams, sleep assistant; risperidone, 5 milligrams, antipsychotic. These are designed to slow down the aggression, to slow down the self-injury. Topiramate is the anti-seizure medication, and lorazepam is the benzodiazepine. Guys, that slows everybody down. Lorazepam can be used as an anti-anxiety medication, as a sleep assistant, as a pain reliever. Unfortunately, benzodiazepines, when you see that in a 21-year-old male, you have to understand it comes with its own weight and side effects and other risks that are involved with using that medication. This is a physician with their back against the wall, guys. They weren't sure what else to do. They had no other treatment options. This is before CBD became recognized in this condition. The last medication on that list is citalopram, which is an SSRI, again, meant for mood stability, to help, again, with the aggression and the self-injurious behavior. Current treatment is special school, which he absolutely loves to attend. And again, this tells you that this individual has love, care, and interest for certain areas of life that are normal, but does not have normalcy when it comes to communication and all the other things that come with ASD. The treatment plan for Apollo includes CBD in the day and a combination based on age, both CBD and THC in the evening, okay? There is importance in consultation with a physician, guys. This is why we know that THC can potentially be added to this demographic if the case suits. There are age requirements. There are other therapies tried in requirement as well. 6-month follow-up with this patient was very interesting. Caregiver states that he is sleeping on average 6 to 7 hours per night now. I know it's not huge for some, 4 to 5, 6 to 7. For them, that was life-changing. Self-injurious behavior has reduced, but still present. Noted lower levels of aggression and decreased incidence of seizures. Their neurologist was surprised. Their family doctor was surprised. Their caregivers were surprised, and we at Apollo were exuberantly happy, because that's a victory for us. That we feel that we have helped that patient, and in a world where this medication can be potentially demonized or potentially disregarded by other physicians who do not fully understand it, we are able to help them, and we'll be able to expand that education. As you heard from Dr. Williams, sometimes a physician is reluctant to get into the world of medical cannabis, and that's because they haven't heard much about it, or they haven't seen many of the studies. This is an important opportunity for me to explain that anytime a prescription is written, the physician must decide, is it worthwhile for this patient to use this medication and all of the potential harm that may occur, or should I skip? And in this particular case, the argument can be had, is cannabis helpful? We're observing that it is. right? But what we do know for a fact is that doing nothing at all and not prescribing any other treatment options will lead to this route. And that route has not always been positive for ASD. The studies show that it is a difficult chronic condition that will last the lifetime of the patient. And again, treatment options have not been updated for a long time. It is now attaining more attention, right? And we are discussing it, we are learning it, but we still have a lot to go. This is a little bit more of a complex case. All right, guys, that brings me to the end of what I've prepared, and I'm just going to take the opportunity to go through a couple of the questions that were sent in. Okay, guys, the first question we want to get to came to us, and it states, is CBD the last line of defense towards ASD? Great question. Right now, I would say that it is no longer the last line of defense, and it's kind of being pushed up in importance and value to patients. But yeah, go back a couple of years ago, it would be cannabis-based medications if nothing else worked. Now, like mentioned in Dr. Williams' video, and as I'm telling you now, this medication as a treatment option is really picking up traction. We're getting more and more patients coming in at an earlier rates, which is fantastic. We like that. Keeping in mind, anytime a treatment is initiated for ASD, time is of the essence. The sooner the better, the more chance of success. So great question. Thank you for sending that in. Okay, the next question is asking, can CBD be used alongside other medications? Well, based on the second case that I went through, the answer is yes. Cannabis-based medications can be used with most other medications. This is why it is so important to have the consultation of a physician, guys. There are many people that come to our clinic and say, well, we gave it a shot. We attained the oil from X, Y, and Z and from this place, but we never spoke to our doctor about it. We just wanted to try it. Well, why not discuss it with a physician? That's my question then, first and foremost. If a doctor is involved in your care, they can go through all prior medications, give you an understanding of dosing, and give you an understanding of what to expect, right? So it's very important, it's almost unequivocally important to have the consultation of a physician if you're looking to use cannabis-based medications with any other medications in your regime. So yes, it can be. The consultation is designed to ensure patient safety first. So great question. Thank you for sending that in. Okay, guys, the next question is, how do I know if CBD is helping my daughter who is nonverbal? That's a really good question, okay? And it comes back to almost with the diagnosis of ASD. Okay, guys, observation and monitoring. Remembering, we don't have an objective test for ASD. It is observation, monitoring, and we have to really dissect what's going on in the day-to-day life of that patient, okay? So for example, behavioral changes, less aggression, okay, less self-injurious behavior, right? More interest in individuals around them, okay? Again, those are just things that can potentially be presented. Sleep is another very important one for us to monitor, right? So when we measure sleep, we don't measure it on a nightly basis. Oh, great, he slept tonight, so that means it's working. Well, potentially, yes, it is working. Yes, he did sleep that night, but we have to look at the long game. We want to know over 30 days, over 45 days, what has been the average of sleep, okay? I mean, if you have a positive night, that's fantastic, and I'm happy to hear it, but let's see what it does over a course of a month. And if we can increase averages, well, then guess what? We're increasing quality of life, and we're helping everybody involved in that hustle again. There have been documented cases of people using visual cues to communicate with ASD patients. They can point to happy, sad, hungry, full, whatever they're feeling. These are met with variable levels of success, keeping in mind that 90% of all communication is nonverbal. These patients are nonverbal, so we have to just use observation. We have to keep a very close and keen eye on all of their activities. And that's how we would be able to monitor success through observation. Okay, guys, so that brings us to the conclusion of this presentation. I want to thank you guys so much for all the questions that you sent in. I know this is a bit of a hot topic and a very popular one. If I didn't get to your question at the end and you didn't feel that I answered it through the course of the presentation, please send them to us. I can try to answer them to the best of my ability and the clinic's ability on an individual basis. The email address is here at the top, marketing@apolloresearch.ca for any additional questions, or if you have any ideas for our next presentation. And of course, thank you so much for tuning in, for all the continued support. Signing off, take care, bye-bye.